Welcome to the Explainer. So, have you ever wondered how we can figure out exactly what's going on inside the hidden microscopic structures of the human ear using literally just a vibrating piece of metal? It's pretty wild when you think about it. Today, we're basically playing diagnostic detective to decode hearing loss. We're going to look closely at two incredibly elegant classic clinical tools, the Weber test and the Rinne test. By the time we wrap up this explainer, you're going to know exactly how these tests work, what they measure, and how they help us pinpoint the exact nature of a patient's hearing loss. Let's get right into it.
Okay, let's dive into this roadmap really quick. First, we'll cover assessing hearing acuity. Number 2, performing the Weber test. 3, performing the Rinne test. And finally, number 4, comparing Weber and Rinne. Having this structure is really going to help us compartmentalize these two distinct but super closely related procedures.
Section 1. Assessing hearing acuity.
So, it all basically boils down to identifying the core problem, right? When a patient presents with hearing loss, our foundational goal is figuring out which of two main buckets it falls into, conductive or sensorineural. Conductive hearing loss simply means there's an impaired sound transmission getting to the inner ear. You can kind of think of it like a massive roadblock on the highway. The sound waves just can't get through the outer or middle ear effectively. Sensorineural hearing loss, on the other hand, involves impaired auditory nerve conduction or a problem with the inner ear function itself. So in this scenario, the sound waves are actually arriving, but the neurological equipment meant to process them just isn't working properly. Differentiating between these two, that's the exact puzzle our diagnostic detective tools need to solve today.
Section 2. Performing the Weber test.
Now, what's really interesting about this is the specific instrument we're using. We aren't just grabbing any random piece of metal here. We use a tuning fork, perfectly calibrated to 512 Hertz. And you might be wondering, why 512 cycles per second? Well, because that is exactly tuned to the frequency of normal human speech. By using this exact frequency, clinicians are testing hearing in the absolute most functionally important range for daily human communication. It is just a brilliant, brilliant piece of practical design.
Okay, Hugh, how do we actually do this test? It's remarkably straightforward, but your precision here is totally key. Step 1, you just strike the tuning fork lightly against your hand to get it vibrating. Step 2, you take that vibrating fork and place the stem directly on the patient's forehead, right at the midline or right on the top of their head. Try to visualize that for a second. Just a single point of contact, dead center on the skull. By placing it exactly there, the vibrations are able to travel through the bone of the skull equally to both inner ears.
And that single placement on the forehead, it basically acts like a diagnostic compass, pointing straight to the affected ear. Let's walk through this matrix of results together. If hearing is totally normal, the patient hears the tone equally well in both ears. If there's lateralization, it just means they're hearing the tone better in one ear than the other. But here is where the detective work gets so fascinating. If a patient has conductive hearing loss, they will hear the tone only in their impaired ear. Yeah, it sounds a bit counterintuitive, but it's true. However, if they have sensorineural hearing loss, they're going to hear the tone only in their unaffected ear. Literally just by asking the patient where the sound is loudest, you instantly gain a massive clue about the exact nature of the damage.
Section 3. Performing the Rinne test.
Before we even look at how the Rinne test is done, we have got to establish a really strict rule of clinical workflow. You must be absolutely sure to perform the Rinne test after you perform Weber's test. This order of operations is completely crucial. Think of it this way. The Weber test gives us the initial lay of the land regarding lateralization, and then the Rinne test follows up by really drilling down into the specific mechanics of air versus bone conduction in each individual ear.
And this brilliantly illustrates the very first step of the Rinne test. Notice exactly where the clinician places the base of the vibrating tuning fork. It goes directly onto the bone right behind the patient's ear. That's the mastoid process. So unlike the Weber test, which uses the center of the forehead to test both ears at once, Rinne focuses intensely on just one ear at a time, starting right there on the mastoid bone.
Let me guide you methodically through this two-part physical procedure. First, you strike the tuning fork against your hand. Second, you place it over that mastoid process we were just looking at, and you ask the patient to tell you exactly when the tone stops. Here is the absolute key, though. You must note this time in seconds. Third, the second they say the sound is gone, you immediately move that still vibrating tuning fork right next to the ear's opening. Make sure you don't actually touch the ear. And finally, step 4, ask the patient to tell you when that tone stops. And again, note the time in seconds. What you are essentially doing here is timing how long they hear the vibration through their bone versus how long they hear it through the air.
Okay, let's carefully decode these Rinne test results. We're comparing air conduction, we'll call that AC, with bone conduction, or BC. Under normal hearing conditions, air conduction is vastly superior. A healthy, normal patient is going to hear the AC tone twice as long as they hear the BC tone. So mathematically speaking, AC is greater than BC. Now look at conductive hearing loss. Because sound is blocked from traveling through the air into the ear canal, the bone conduction actually takes over as the primary pathway. Therefore, the patient hears the BC tone as long as or even longer than the AC tone. So BC is greater than or equal to AC. Finally, with sensory neural loss, the inner ear or the nerve itself is the issue. So the normal relationship is maintained, but diminished. They'll still hear the AC tone longer than the BC tone, meaning AC is still greater than BC, but the overall times, they'll be significantly reduced compared to a healthy ear.
Now let's move to Section 4, comparing Weber and Rinne, and see how this builds together.
So the crucial point here is understanding the fundamental difference between what these two tools actually measure. Honestly, if you take nothing else away, this is the big takeaway from our explainer today. The Weber test is your go-to tool for evaluating bone conduction globally and checking for lateralization. Basically meaning, does the sound pull to one side or the other? It points you left or right. The Rinne test, which we do afterward, is your tool for direct comparison within a single ear. It specifically compares air conduction to bone conduction to determine if a physical blockage is present. Put them together, and they form a remarkably complete diagnostic picture.
It really is amazing when you step back and look at it, isn't it? Did you ever realize that a simple, vibrating piece of metal could actually map the invisible pathways of the human nervous system? By literally just leveraging the physics of a 512 Hz tuning fork, clinicians can confidently differentiate between a mechanical blockage and complex nerve damage, all in a matter of minutes. It completely highlights the absolute elegance of diagnostic medicine. I really hope this explainer illuminated the brilliance behind the Weber and Rinne test for you, and leaves you eager to learn more about the incredible diagnostic tools being used in medicine every single day. Thanks so much for learning with me.